Welcome to the Availity audio blog. I'm Matt Schlossberg, Director of PR and Communications. We're recording at HIMSS23 in the beautiful city of Chicago, and we're here to talk to thought leaders and industry experts about the opportunities, challenges, and technology solutions behind clinical data acquisition and use. You can learn more about Availity Fusion, our API-based upcycling data technology, online at marketing.availity.com/clinical-solutions. My guests today are Sam Schifman, Chief Architect for Clinical Solutions at Availity, and Adam Cole, Senior Solutions Architect and AVP Sales Engineering at Smile Digital Health. Today, we'll be discussing the meaningful strides FHIR has made in healthcare data interoperability and what's next. Sam and Adam, welcome to the podcast. I wanted to ask you before we really kind of dig into FHIR and the paper you wrote in advance of HIMSS23, if you could tell me each about yourself. Sam, maybe you want to get started.
Sure. Thank you. I'm really glad to be here today and to get to talk about what is a super important topic for Adam and I. My name is Sam Schifman. I'm the Chief Architect for Clinical Solutions at Availity. I've been doing that for about 3.5 years. Before that, all over software, no-code development platforms and finance and HR, and finally got into healthcare. It's been a great ride, and really excited to see FHIR growing up in the community. 2 weeks in, went to my first Connect-a-thon and thought, this is a really cool possible technology. And now being here at HIMSS and getting to see it actually come to fruition is really pretty amazing.
Awesome. And Adam, welcome to the show.
Thank you,
want to
Matt.
tell me a little bit about yourself and Smile?
Absolutely. And so similar to what Sam was saying. I'm quite excited about the potential of FHIR, and as we're seeing FHIR mature and be adopted everywhere, and of course that speaks to the need for data quality, and that's where Sam and I see eye to eye. My personal background, I've been in digital health for 25 plus years. Some interesting highlights. I was VP of IT at the Canadian Clinical Trial Network, where I got to lead the development of the artificial pancreas, and I had some other really interesting roles as CIO, CTO type of roles along the way. And more recently, 3 years ago, I had a great opportunity to join a young Canadian startup company called Smile, and it's just been a wild ride. We've grown really significantly in that period. We make the preeminent FHIR server. A lot of people know Smile, and those that don't likely do know Happy FHIR, which is the open source product which we maintain. And as we talk about FHIR and the all of the potential of FHIR, I talked about it earlier. One of the big challenges now in the interop world is because we do have interop, data quality becomes quite a paramount concern.
Okay, great. Well, both of you co-wrote, I guess we could call it a white paper called Empowering FHIR, and we'll include a link to that paper in the show notes. What's kind of like your top line summary and argument that you were attempting to make in this piece?
Yeah, if I try to distill it down, I think it's really about that fear that FHIR could fail, not because of FHIR. So we think about the example of the security concerns that were raised last year that really had to do with implementations of FHIR, not with actual FHIR itself. But the FHIR community had to respond to that. I'm really afraid that the same things could happen with FHIR trying to get off the ground with bad data. It's not FHIR's responsibility that the data is bad, but it will reflect badly on FHIR. Similarly, if it tries to get off the ground with a FHIR server that's not up to the snuff, lots of things could go wrong just because that implementation isn't prepared to work at scale. And I know that the Smile people are prepared to work at scale, and so that's why I love working with them so much.
Yeah, you hit the nail on the head there, Sam. I have so little to add to that, but there were so many payers and now more recently providers that in a rush to meet the mandate and make sure that they were compliant ahead of the enforcement dates, likely, I don't want to say took shortcuts, but didn't necessarily think about data quality as one of their priorities. And now that they've met the mandate and are starting to exchange data, to your point, there's going to be disillusionment if the data isn't interoperable. And if I'm a payer and I'm getting data from you as a provider and it's not meeting my objectives for reporting HIDA scores or doing risk adjustments or upcoming prior authorization, then to your point, it's going to reflect poorly on FHIR overall. So getting the data quality to a level where we can do meaningful interop is integral.
I also think that that the future use cases that we want to make possible will not be possible unless that data quality is there. I mean, I think, about this project we did with a large state government on COVID reporting. And, we saw over 150 ways that the COVID test itself was represented. But even worse than that, we found over 40 ways that negative was represented. So you think about that computational complexity of 6,000 different ways just to know if somebody had a COVID test and it was negative. When you try to do analytics on that kind of data and recognize the power of things like AI in the future, it's just not going to happen unless you clean it up.
So come back to that, because I find that mind-boggling. 40 different ways to do a negation of a condition.
Yes. Yes.
Can you elaborate on any of that?
So, different people use different codes. So there's slightly different codes, but often people also don't do a code. They do just a description to just say the word negative, or they'll say, SR15 negative, or they'll use, sometimes they'll use Loinquin that should really be represented as SNOMED. They're just a bunch of variations in how different labs decide to interpret what they should put in that, which is what is still an HL7v2 message, right?
So intrinsically, I know that to be true. I find it so fascinating that something as simple as a negative, we can represent 40 different ways. And of course, when we get into diabetes, we see hundreds of different ways to say diabetes. And
we've done some of the same research on HbA1cs and found also over 150 different ways that HbA1cs have come in, and these are in real CCDs. These aren't even HL7v2s that we've seen in real data coming through our system.
So, Sam, you've built systems in other industries. You mentioned, HR and finance. What makes healthcare so much of an outlier in terms of getting data quality under control? What are some of the things that are making it difficult to achieve that?
I don't like to think of healthcare or try to say that healthcare is a special snowflake. It's a different snowflake. It's got its own complexities. I think that a lot of it boils down to the intent of the data. In healthcare, which, arguably the second oldest profession in the world, there's been a long history of how recording of data has come about, right? Initially, a physician had a relationship with a patient in their same town. They only needed to keep the notes that they needed to remember from one visit to another, right? Then you get doctors coming together into institutions like hospitals where they only needed to communicate with, somebody might see a couple people in the same hospital, but they only needed to communicate with each other. These institutions were really islands in themselves, and they grew up with their own ideas of how to record data and what was important to record. As we try to bring that into interoperability, that's really difficult. You compare that to something like a financial ledger, right? Financial ledgers were invented sometime, BC or something like that. I forget the actual date, but they've been around forever. The dual ledger system has been around forever. Everybody understands that. So there's a lot of complexity in finance, but it's not grown up quite so separated. It's not quite so island based.
And finance it's a very precise measurement.
Yes.
And there's a lot of fuzziness around healthcare data, and there's an art in interpreting and explaining what you see as a doctor. And so that lends itself to a whole realm of fuzzy data.
Yeah, and I think you can interestingly see fuzziness in finance, but it's never really fuzzy. Like you can get, like we take 2008 where we had all these problems, all the various financial vehicles that people invented around that time are all a little fuzzy, but in the end they've resulted in numbers and they were all provable. Whereas in healthcare there just isn't, right? Like you just can't. There's always a probability that whatever diagnosis I gave is wrong and that it's something else, right?
So I wanted to ask you guys specifically about FHIR as a standard. There's several different kinds of standards in healthcare, but certainly in the last couple of years, FHIR has been kind of seen as the belle of the ball in a lot of ways, as the tip of the spear. I don't know how many different analogies I can use, but what is it about FHIR that really makes it such a promising and accelerating standard for healthcare to adopt at scale?
Well, I've got a sticker on my laptop that says open standards. And I think that's a great place to start. FHIR is open, and you're not getting into walled garden as many EMRs tried to lock you into it. So right away, it's excellent for interop. If we look at how it's developed and its maturity cycle, I tend to bristle at bureaucracy and the 6 different maturity levels in FHIR, and how they take significant amount of time to go from one level to the next. You have to go through connectathons and testing and balloting, etc. Normally that's not something that appeals to me, but in this case, I think that the fact that it is community driven and the way that it is evolved and significantly tested before anything becomes normative, by the time it is normative, we know that it's going to be really useful. And so we have less concern about working with something that's, okay, it's going to fit this use case. But again, when I go to do interop, oh, shoot, we forgot about this edge case or that edge case. And then we have to throw Band-Aids on top of it and wind up with the zoo of extensions and additions, which make all sorts of complications to prior standards.
I couldn't agree with you more. I think just the experience that HL7 has had with building these standards makes just a huge difference in what FHIR has been able to become. I mean, you think, there was a V1, but nobody talks about V1. So we talk about V2, right, as a standard which was really built to be a point-to-point protocol over modems, right? But they got their start there in understanding what data needed to be flowing. And then the CCDA standard comes along. It brings all that information into a much more structured document, but it runs into this problem of being huge, which is just not effective when you want to talk about modern apps that run on mobile or places like that, right? So HL7 learned from all that, and then they figured out how they were going to build the next standard. They learned that they needed to think about APIs. So they needed to think about not just the data format, but also how the data was going to get communicated. They realized they needed to split the data into these smaller resource pieces so that you could fetch, when I go into the emergency room, I don't want my, to see my full family history at the top. I want to see the allergies, and I want to see my problem list, right? And FHIR lets me get that information and then go for the rest of the information when I need it. And then finally, they built in extensibility from the beginning, which, just shows that they understand that no standard's ever going to be perfect. No standard's ever going to get everything. But if you have a framework to allow for extensibility, then you're okay. You can always stick in those extra fields that you need. So I think it's really experience on their part that's leading to their success.
One question I had about FHIR and the use of APIs is that healthcare in general and the regulatory state have definitely been pushing for more patient centricity in healthcare, having patients have greater control over their data and how it's shared, how it's accessed, and how they make informed decisions. So do you believe FHIR, among all the other standards, is the more quote unquote patient-friendly standard?
Is it a more patient? It's certainly a more application-friendly standard, which then turns around to be more patient-centered, because the reality is I'm not a medical professional. I'm not a doctor. My parents aren't a doctor. None of my, I do have some friends who are doctors because I now work with them. But understanding medical data, if you don't speak the lingo, is incredibly difficult. So I need tools, and this is where I actually believe AI is going to have a huge impact. I need tools that are going to let me understand not just my data, but more importantly, the data about my parents. They're aging. They're getting into that block of time where they're going to have a harder time understanding and navigating the medical world. And I'm really going to need to be able to help them out. And so what I think is excellent is that FHIR is so friendly to those people who want to build the next generation of tools that are going to let me connect to my parents. And the whole consent models around FHIR are starting to grow up to allow that. And I think that that's really a fascinating possibility for the future.
I like that. And as you asked the question, I think if we reframe it just slightly, or if we think about patient centricity, it's not necessarily giving the patient access to the data, which to the CMS's credit and ONC, they've been very clear about through the patient access API, the patient has the right to access their data through any third-party application of their choice, and I love that. But if we think about patient centricity as to what's going to provide the best care for the patient, then absolutely FHIR plays a really important role there. Again, coming back to the fact that it's interoperable. So as a patient, my healthcare data, as we progress forward, no longer needs to be siloed and have all sorts of gaps when I go see a new specialist, or I'm in the hospital, or in my primary care doctor. They're able to see as complete a picture as possible. And so that, of course, leads to better care, better outcomes, lower costs, more efficiency. And to me, that's better patient centricity.
And, beyond the public and private push for FHIR, what I found really interesting about the way your paper opened is that you really describe a confluence of, honestly, existential events, such as the aging population, the so-called silver tsunami, the increased prevalence of chronic conditions, and of course the crisis of burnout amongst healthcare workers, particularly post-COVID. And those present serious risks to the health of our healthcare system. And I was wondering if you could talk a little bit about how you imagine data quality and FHIR standardization can mitigate the worst effects of those issues.
I feel very strongly, actually, about this subject. I think that FHIR and getting more patient-centric is the way that we need to do this, because we're looking at this crisis coming up for the healthcare system, and the only way that we're going to attack it is with preventative care. But as I just said, the people are not medical professionals who are going to be doing this. Health plans are going to really have to learn how to partner with their members to get them the right preventative care, but they're not going to be able to hire enough nurses to do that, right? And they're going to need the accessibility to clean data in order to understand what they need to do. And they're going to need AI on top of that to help them interpret that quantitative data into a qualitative story that they can really understand. And admin staff at a health plan can reach out to a member and say, hey, you need this preventative care, and I'm going to make sure that you get an appointment for this thing. Whereas this other member doesn't need it today. They can have it next week, right? Similarly, I need that ability to help my parents understand, yes, like you're based on your smartwatch, data is coming in and I'm seeing that you are having some mental issues, decline issues. And now I know that I need to make sure you get to see the right professional about that. So I think all of that is only possible if the data is understandable, and to have it be understandable, it needs to be clean and it needs to be interoperable. That's just critical.
I agree with you 100%, Sam. And just to provide some specificity to what you said, at Smile, we recently acquired Alphora, and those of you in the FHIR world will know Bryn Rhodes and his team. A bunch of really brilliant people who have a clinical reasoning engine. And for the clinical reasoning engine to work, which is providing decision support, it's working off of, decision support is running off of computable data. And for computable data to be meaningful, it needs to be standardized and hygienic. And of course, that comes back to the root of your question, Matt.
Absolutely. So I wanted to turn and ask a couple of questions about the future and about HIMSS23 itself. So, Availity obviously supports and will continue to support several different kinds of standards, but do you imagine at some point in the future that healthcare is going to converge on a more singular standard, or do you imagine there will always be a place for multiple standards depending on specific use cases?
We have HL7v2 still floating around as probably the majority of healthcare data, right? Even though the government, 10 years ago said that EHRs needed to be able to put out CCDAs. I think that healthcare doesn't shift overnight, but I do think, largely based on what I've seen at HIMSS here, when I compare what was going on when I went to that first Connect-a-thon to how much influence FHIR has had, and look over there at that amazing interoperability showcase, I realize that FHIR is going to be transformative for the future. I don't think we can say we're just going to drop all those other standards and there's never going to be another CCD ever produced. I don't see that happening in my lifetime, but I do see the really innovative stuff and the interesting stuff happening because that data has been converted to FHIR. And that's why at Availity, we think, we focus on how do we get high quality data out of legacy formats into FHIR, because we think that bridging those gaps are going to be super important for a long time.
Yeah, pick up on that. I agree. I mean, FHIR has so much value because it is open and community driven, and it's global, and it addresses if you're familiar with it, the 80-20 rule. It addresses 80% of the use cases. And then to Sam's point, it does have the extensions meant to address the extensions, but there's always going to be other areas where FHIR is not necessarily the most appropriate standard, like DICOM. I'm sure we could list some other specific niches where they're going to have their own standards. But for the ground truth, or the fabric that connects all the various points in healthcare together, that I do see the world moving towards FHIR, and FHIR being the definitive standard into the foreseeable future.
With more provider and payer organizations looking at FHIR as a viable path forward, certainly your paper suggests that data quality has to kind of go hand in hand with that kind of adoption. So my last question to you guys is I thought you could each talk about how Availity and Smile Digital Health kind of help feather the nest for these organizations to ensure they have the data quality standards to optimize FHIR to its greatest abilities.
Yeah, let me start on it with that one, if that's okay. So Smile, we have an excellent FHIR server, and we've got all sorts of capabilities in there, including a number and most of the FHIR operations. And so we provide the tooling for an organization to create a health data fabric, and to do so with high quality data, but to actually do the act of data hygiene and upcycle the data. That's where we look to, our excellent relationship and partnership with organizations like Availity. Well, not like, specifically Availity. They're second to none.
One of the things I love about working for Availity is that we continually focus on what we do well. We have been doing the upcycling of clinical data for over 10 years now. We do it at scale. We produced 8 billion resources for one of our larger clients recently, across like a 2-week historical load of all their data, which is a pretty impressive feat. But we've recognized that we're not gonna be the best server of that data. We want to focus on doing what we do and producing the best quality data that we can, so that people like Smile can do things like make bulk FHIR available and make CDS hooks available and things like that, which are super important, but are going to stretch us in ways that we don't need to be stretched because they're doing such a great job of it. So I just see this partnership as just like peanut butter and jelly. We're just, and I think that as we build this fabric, or I call it the Internet of Health, but Smile talks about it as the fabric of healthcare. I think that all those pieces are going to need to come together, but you can't have any one organization be experts at all of it, because the 10 years of our clinical informatics team of doctors and pharmacists and clinical informaticists looking at data, looking at real data, is what's necessary, to make a system that's actually going to clean up the data. And not everybody can make that investment, and quite frankly, not everybody should make that investment. It's a big investment, and it's not useful for everybody if we can provide that for them.
Just to geek out for a minute here, because both you and I, Sam, we do this offline a fair bit. We have a passion for AI and love the potential, and we've talked about this long before the ChatGPT explosion a few months ago. But we can't ignore that elephant in the room. It's everywhere we turn right now. There's .ai everything, and no doubt a lot of the companies here are looking for, and a lot of our customers are looking opportunistically to AI and AI decision support, and of course, AI is only as good as the quality of data that goes into it.
The example that I always think about is metformin is a very common drug prescribed for diabetes, right? But if you have metformin and diabetes represented in hundreds of different ways across your medical data, and you try to build a model, a AI model off of that, you're going to end up with a weak association when it should be a strong association. Whereas if you clean up that data ahead of time, then you can notice that, metformin's a strong association with diabetes. If I see somebody who's taking metformin but doesn't have a diagnosis of diabetes, there's a high probability I should flag that, right? That sort of thing only becomes possible if the data is clean, and the data is clean at scale. I mean, we talk about large language models are all over the place right now, right? You can't just have a few hundred documents that your data scientists have cleaned up. You've got to have huge data at scale to make these models work. And that's where Availity shines, at our ability to do that at scale. And quite frankly, also Smile shines at its ability to handle that data at scale.
And for an instance like metformin, it is used off-label for things other than diabetes. That's what you're kind of talking about.
Yeah, so I mean, it's used off-label for other things besides diabetes, but it should be a strong association with diabetes. This gets into the fact that AI is never going to replace doctors. We can't actually look at AI as being the solution that's going to replace doctors, because the data still needs to be interpreted, because people are fuzzy. Very much as Adam said near the beginning, the healthcare is a fuzzy problem. But AI can help. AI can flag that record as saying, this guy's got metformin. He doesn't have a diagnosis of diabetes. Why is that? Maybe it's because it's being prescribed off label, but maybe it's because the person who is transcribing the notes from the doctor missed it and just didn't put in that diagnosis, right? But the medication went through the pharmacy, so that got into the record anyways, right?
Well, Sam and Adam, thank you for coming on the podcast. I think this was a terrific discussion, and we will include a link to your paper in the show notes, as well as contact information for both of you, and particularly you, Adam, with Smile Digital Health.
Thank you, Matt. Thanks, Sam.
Yeah, it's been a real pleasure. It's always great to talk to you, Adam and Matt. It was the great questions.
Awesome. Thank you very much. All right. Talk to you guys soon.